appendix. That's why patient feels pain in the right iliac fossa. Copious Schwarz test, it is elicited when the appendix is retrocecal. Then if we hyperextend the right leg and take it backward, when the appendix touches the Schwarz muscle, then patient have pain. Similarly, Operative test elicited to know for pelvic appendix and Murphy's sign. We all know Murphy's sign is a diagnostic of acute cholecystitis. Coming next, guarding and rigidity. Guarding and rigidity are somehow different. Guarding is voluntary. The patient is having pain and he is restricting pressure to that area. That's why he causes strengthening of the muscles of the abdomen. But rigidity is, it is involuntary. Disease is progressing inside the abdomen. It is causing peritonitis. That's why there is tightening of the muscles of the abdomen. So guarding is good sign. Disease is there, tenderness is there, guarding is there. It is protecting the patient. But if there is rigidity, but then it means that the patient condition is not good and he is having peritonitis and sepsis. Then rebound tenderness generally not elicited because it is very painful to the patient. We poke the finger in the abdomen and release it. Once we release it, patient cries with pain. It is generally not done. And on palpation, we have to find out if there is any mass. Then percussion. Percussion is important in two cases only. Whenever we suspect perforation or ascites. In case of perforation, there is a accumulation of gas in, just above the liver and under surface of the diaphragm. So there is loss of liver dullness. Generally, whenever we percuss from the second intercostal space downward, from the fourth intercostal space, there is a liver dullness is present. When we percuss, then it will be dull. But in case of perforation, due to presence of air, this dullness is lost. It is called loss of liver dullness. And in fluid, we elicit fluid thrill or septic dullness. Auscultation, in case of obstruction, early stages of obstruction, when the bowel is functioning, then we will see borborygmy. But in later stage of obstruction, when there is fatigue of the bowel, then we will not hear bowel sound. And that is then hyperactive bowel sounds are generally found in early obstruction. And absent bowel sounds are found in peritonitis or later stage of obstruction. And parectal examination, no abdominal examination is complete without parectal examination. If you don't want to put your finger inside the rectum, put your toe. It is written in Bailey. So it is that much importance of parectal examination. Suppose patient is having distension of abdomen, we advise him for investigation. Just today one case. A patient came with distension of abdomen and bleeding per rectum. I examined the abdomen, it was hugely distended. And when I put the finger inside, obviously blocked finger, so there was, rectum was full of hard stool. I could not break it manually. Once I had broken some part and advised him to go to the toilet, he came from the toilet, again I did manual, then only I sent the patient for ultrasonography. Ultrasonography was done and patient passed stool nicely after giving another India casualty and patient left. He was an aged person and his distension was due to hard blocked stool and that stool was causing bleeding from the rectum. So this is the importance, and sometimes we feel rectal growth or anal growth, and sometimes important is in intersubception. When the ileum goes through the colon, then sometimes the tip can be palpable in the parectal examination. Now we will discuss everything in case discussion. So what are the red flag signs? Red flag signs means we have examined the patient, we have checked his general examination and systematic examination. Now what are the signs that it says that we have to call the surgeon or medicine specialist immediately? These are severe continuous pain. Pain is not relieved. Sudden severe pain with collapse. Suppose a patient had road traffic accident, he was taken to the hospital, suddenly patient collapsed. That means he may have splenic rupture or hepatic laceration. he is in collapse because of shock. Then tachycardia, hypotension, rigid abdomen, that means rigid abdomen means peritonitis. Absent bowel sound, peritonitis. GI bleeding, septic shock, or altered mental status. All these indicate the patient is in serious condition. We have to act accordingly. A patient with shock and abdominal pain should always be considered as surgical emergency until prevented otherwise. Shock and abdominal pain. That means this patient is surgical candidate. Now coming to the investigation. The routine blood test. Whenever you see such a case, we have to do the test for diagnosis and also to prepare the case for surgery. Surgery may or may not be needed. But if we don't advise this test, if we later determine that this patient need to be taken to the OT, then it will take another 2 hours. That is why we have to advise the test at the first visit. If we merely suspect that this is surgery candidate, those are CBC, blood group, and CBC total count. It indicates our hemoglobin, whether patient is anemic or not, or total count. It indicates whether patient is in sepsis or not. CRP, blood group, important for surgical part. Serum electrolytes, because sometimes patient may have pseudo obstruction, patient may have electrolyte imbalance. That's why patient is having obstruction. Then LFT, RFT, blood sugar, serum amylase lipase, pleural pancreatitis, ABG, coagulation profile, and pregnancy test. In reproductive age group, if a lady presents with pain and pallor, always do pregnancy test. Coming to the investigations, we have a variety of investigation like X-ray, ultrasonography, CT scan, MRI. But which investigations is needed for which patient? We discuss it in respective topics. So coming to the management. So I previously told, examination of the patient and management should go simultaneously. Suppose a patient comes with severe pain abdomen, difficulty in respiration, you check the airway, at the same time ask the sister to make oxygen supply ready. Patient is having feeble pulse, you have just check feeble pulse, ask the sister to insert cannula on the opposite side. Patient is dehydrated, ask the patient sister to transfuse blood. If blood is not available, to transfuse IV fluid at fast. That is why diagnosis and management runs simultaneously. So the general principles are knee loadally, IV fluid, oxygen, nasogastric tube if needed. Patient is having distension, insert nasogastric tube, no problem. Police catheter, most important part. Police catheter gives us assessment of the urinary function. Most of the patients comes with dehydration, takes multiple Doloni injection at home by local pharmacist. Then patient has kidney dysfunction. That is why always insert a police catheter. Even if you don't insert ice tube, no problem, but insert police catheter. Then pain management. For pain management, better to go with contramol first, because we don't know his kidney status. That is why go with contramol. Antibiotic, better to start with broad spectrum antibiotic like piperacillin, tazobactam, or meropenem, because ceftriaxone is now used so hugely at the periphery level that it does not grow. And if you suspect an abdominal obstruction or perforation, add metrozine. Then monitor vitals. Early aggressive fluid resuscitation is life-saving. Another important point regarding fluid resuscitation: whenever you think patient is in shock, our aim is just give one fluid in this hand and another fluid with noradrenaline on the opposite hand. This concept is wrong. Whenever there is fluid depletion in the body, if you give noradrenaline, it will harm the patient. Noradrenaline works when body has abundant fluid. That only it causes vasoconstriction and increase the cardiac output. But if there is no sufficient load inside the body, how will it can pump out? So, if patient is in shock, whether it is hemorrhagic shock or due to dehydration, give at least 4 liters of fluid within first 2 hours. Then you add adrenaline or noradrenaline. Now coming to the separate identities, acute appendicitis. This is the most common presentation, and everyone we have faced acute appendicitis in the emergency. the patient comes with a history of pain around the umbilicus, then it is shifting to the right iliac fossa. It is due to, because the appendix is mid-gut organ, and any mid-gut organ causes pain in the around the umbilicus. Once the appendix becomes inflamed and it causes irritation of the parietal perineum of the right iliac fossa, then patient has pain in the right iliac fossa. So sometimes whenever patient comes with around the pain around the umbilicus, we also miss appendicitis. But thanks to the newer investigations, we can diagnose appendicitis at the earliest stage. So patient has fever, then vomiting is common, and anorexia is also common. It is written in Bailey that if a patient with anorexia, if a patient does not have anorexia with pain abdomen, then appendicitis is unlikely. Then there is definitely that is the MAY'2026 point. And investigation CDC, we have to look for leukocytosis, ultrasonography. The appendix is very difficult to detect in ultrasound always. But if it is severely inflamed, there is lump, it will be obviously detected. But simple appendix is difficult to diagnose. Then in that cases, we have to do CT scan. So management. If patient is in stable condition, most important part, if the patient has presented with appendicitis and you have diagnosed it is within 72 hours, probably patient has not developed a lump. If after 72 hours, patient generally, acute appendicitis patient generally presents with lump. If there is lump, then it is very difficult to do surgery at this condition, because lump is, appendix is surrounded by a small intestine. So if you go for surgery, it is there is very high chance that we can injure the ileum or patient may have fecal fistula. Yet, though the chance is 10%, but 10% is very more. So management, conservative like insert cannula, IV fluid, painkiller, antibiotic, then investigations. If it is clinically suspected, and always whenever you suspect any disease, write a provisional diagnosis. Query appendicitis, query cholecystitis. Then the radiologist is well versed that what organ he has to pay importance, because one sonography of the abdomen in detail may cause more than 30 minutes. But if you give a hint to the radiologist, then he says that I have to pay more attention to this organ, then we will get the report within 5 minutes. So what are the complications? Treatment is, if patient is operable, then do appendicectomy, whether open or laparoscopic. But I said laparoscopic appendicectomy is better nowadays. What are the complications? The complications are perforation, abscess, and peritonitis. The first picture shows it is a acute appendix. In this case, appendix is swollen, but it is operable. But the second, we see this case came with a history of pain abdomen and ultrasound done 3 days back, showing polylithiasis. Whenever I examined, I found that severe tenderness in the right iliac fossa. I sent for ultrasonography, relating acute appendicitis with polylithiasis, and diagnosis came with appendicular lump with polylithiasis. Early lump, that's why I operated it. And you have seen, these are the parts. You can see, parts comes out. That means it is already perforated appendix. This is first. So appendicular perforation is a very dreaded complication. Surgery for appendix is a bread and butter for the general surgeon, but surgery for appendicitis can take the surgeon to the goal. That is why nowadays generally no one is willing to operate in a case of lump abdomen or appendicular perforation. Acute cholecystitis, we are all versed with this. It is generally patient presents with pain in the upper abdomen, and when we do examination, there is tenderness, along with patient may have fever, vomiting, sometimes patient may have jaundice. The routine investigation, ultrasonography and LFT, along with other blood tests. And alert, some people come with that I have gallstone, I want to do a CT scan. The gold standard test for polylithiasis is ultrasonography, because only 10% of the gallstones are radio opaque and detected in CT scan. Otherwise, ultrasonography is the investigation choice for polycystitis at least in our country. In outside, MRI or MRCP is done, but in our radiologists are very good, they can detect cholecystitis easily. So management, this is a case of acute cholecystitis with impending perforation. So the same thing happens with cholecystitis also. We have to, if it is acute, we have to operate within 72 hours. After 72 hours, there is very high chance of perforation. That is why always go for early cholecystectomy. But it is generally not possible because patient comes with history of pain for 2 days. First day they take medicine from pharmacy. Second day they come to hospital. Diagnosis is done. We say that patient needs urgent surgery. They says, let me go home and we'll come next week. So generally we don't get cases at proper time. That's why more of the complicated cases nowadays. Hollow viscous perforation. It is the important topic from today's point. Hollow viscous means bowel which contains gas. So it may be stomach, duodenum, ileum, colon. So common causes are similarly peptic ulcer disease, typhoid perforation, tuberculosis perforation, traumatic perforation. Typhoid perforation and tubercular perforation are very rare nowadays due to treatment. But whenever I did thesis, it was a small bowel perforation, and I found that after trauma and duodenal perforation, typhoid perforation was more common than other perforations involving ileum. Whenever you see a case of perforation, you should not miss it. Patient will be dehydrated, sunken eyes, he cannot lie properly on the bed, abdomen is distended. Whenever you see he is dehydrated, there is pallor, patient may some pallor. Then whenever you do examination, there is tachycardia, patient is in shock. Then abdomen is distended. There is distended and severe tenderness, guarding rigidity. If rigidity is developed, then probably it is a old perforation. Approximately it has crossed 3 to 4 days. So what investigation we will do? The investigation of choice whenever you suspect a case of perforation is chest X-ray PAP erect including diaphragm. If diaphragm is not shown in the X-ray, then we cannot properly say whether it is perforation. So always write chest X-ray PAP erect view including the diaphragm. Ultrasonography is also done. If needed, sometimes concealed perforation, we cannot detect concealed perforation. That in those conditions, we need CT scan. So management is ABCDE, IV fluid, resuscitation. Then if you are in confusion, patient is having but it is likely to have perforation, do insert a needle at the site of most dullness and aspirate. It will show you bile or pus. That indicates that the patient is having perforation. Whenever there is not availability of X-ray or ultrasonography, then this test helps. So emergency resuscitation, exploratory laparotomy, closure of perforation, mental pets, gastric lavage. Lavage is most important because if we don't wash the perforated part with NS, it is written that approximately we have to give lavage with 6 to 10 liters of NS. Otherwise, the septic focus will not go out, and we should not delay. Whenever when I was doing PG, whenever a patient of perforation comes to the emergency, it is my duty to make the patient ready for OT within 2 hours in case of perforation, because every hour delay increases the mortality of the patient. So this is a traumatic perforation. The patient came to OT. This is a sigmoid colon, and stool is coming out from the sigmoid colon. After thorough examination of the small bowel, no perforation was found, but there was fecal smell. So that's why I examined the sigmoid colon, and it was perforation was involved in the sigmoid colon. This is a case of septic perforation. A case history of approximately 10 days plain abdomen. Patient was kept in Nagaon medical class for 3 days, no improvement. He was taken to Guwahati, referred to Guwahati Medical College. At that time, I was at Mercy, and patient was taken to Mercy Hospital because patient becomes senseless. And immediately, I operated the case without waiting for the investigation. And see, huge amount of pus inside. Pus DB, all people, I myself inserted the cannula, and after giving one fluid bolus, patient revived. In this, so where you can see multiple ileal perforation, and main problem is patient had almost 10 days delay from the diagnosis. Patient developed biliary fistula, and that fistula was approximately for 6 months. After 6 months, it healed spontaneously. Now the patient is fine. Intestinal obstruction. So patient with intestinal obstruction may have different causes like adhesion. Most common cause is adhesion. It is generally seen after previous surgery. Adhesion then, and the intestine becomes knotted around the band. Then hernia, tuberculosis, stricture, and in case of large bowel, it is malignancy or volvulus. Volvulus generally seen in old patient. Clinical features are similarly pain, abdomen, distension, vomiting, and constipation. And investigation is this time X-ray, abdomen, PP erect, and CT scan or ultrasound. One differentiating point between the obstruction is also seen in case of perforation, because after perforation due to adhesion there is some kind of obstruction. How to differentiate? In obstruction, generally there is abdomen is soft. There is distended bile loop, but it is soft. But in case of perforation, abdomen is not soft. It is almost rigid. This is the differentiating point between obstruction and perforation. Even sometimes it is difficult to differentiate because patients present late. So management is also similar. Desensitization. Then in obstruction you have to insert cannula. In obstruction and perforation you have to insert catheter and patch tube both. Then IV desensitization and surgical will take the patient to the surgery, and accordingly we proceed with erythrolysis, or if there is growth like malignant surgery, or if there is hernia repair. So strangulated hernia. In this case, the bowel is entrapped within the hernia sac, and at the same time the vascularity is compromised. This is a case, Nizor Borba. He had hernia. I always asked him, please come and do the surgery. He does not come. One day I went to hospital. He said that now 2 days it is not going inside, and there is severe pain. So I took him from boarding out to our hospital. Just NAMC Hospital was opened approximately 15 days back after opening the hospital. Thus you can check the color of the bowel. He had pain from 6 p.m. I operated him at 11:45 because after 6 hours the bowel becomes non-viable. You can check the color sense. This is the normal bowel, and this is the strangulated bowel. If we had waited for more than 1 or 2 hours, probably we have to dissect and do dissection anastomosis. Just did hernioctomy, hernioplasty, and patient survived. Now he is fine. He is asking me. Yesterday he called me that I have to go to their room for Eid celebration. But it's a very dangerous condition. Generally, what happens, we miss the hernia. Then always, in case of obstruction, always look for hernia. Acute pancreatitis, it is common for both medicine and surgery, because etiology is different. In medicine, it may be due to alcohol or hypertriglyceridemia. In surgery, it is due to biliary pancreatitis, but management is same. One principle, always aggressive fluid resuscitation, because pancreatitis patient loses about 3 to 6 liters of fluid intraperitoneally. It is called third space loss. It is inside the abdomen, but not in the circulation, in the form of ascites. That's why even if patient is having ascites, we have to infuse fluid. Sometimes we may need to give fluid at the rate of 3 to 5 liters per day. And at the same time, we have to insert catheter, and we have to monitor input output. Antibiotic says it generally has no role, but if you suspect infection, imipenem has some role in case of pancreatitis. Otherwise, only fluid management and pain management is sufficient for management of case of simple acute pancreatitis case, but it is the necrosis or something like that, severe form of pancreatitis, then we have to go with antibiotics. Sometimes patient may be shifted to the ICU, and acute necrotizing pancreatitis, the severe form, it has very high mortality. In the first picture, this is the pancreas, normal pancreas, well outlined. But in the second picture, this is the pancreas, and you can see air inside the pancreas. It is due to gas forming organism or due to communication of the pancreatic duct with bowel. Then it is very severe form of pancreatitis. The patient is in the ward, and they are taking the patient to Delhi tomorrow. So surgery is not always needed in case of complicated pancreatitis, but it may be needed if there is diffuse necrosis of the omentum inside the bowel. Then we have to do necrosectomy, or sometimes for complication. Ascitic patient is having ascites in case of pancreatitis, but why we do not do ascitic tapping? Patient is having discomfort because there is risk of fistula, kidney fistula. That's why we generally don't do tapping. But if patient is in distress due to the fluid, then we may consider for ascitic tapping. Otherwise, ascitic tapping is not needed. On conservative management, the fluid will disappear. Mesenteric ischemia. This disease don't give you time. So mesenteric ischemia is somehow the mesentery is supplying blood to the bowel, gets blocked due to torsion or some other causes. Then bowel becomes gangrenous. Here one dictum is, you examine the patient, abdomen is soft, no distension, but patient is crying with pain. The one term is, pain is always out of proportion of the finding. Whenever a patient comes with this kind of pain, he is tossing in the bed, you examine the abdomen, completely normal, mild tenderness, no distension, always think of mesenteric ischemia, because we don't have time for mesenteric ischemia. If we don't operate within 6 hours, the bowel will get necrosed. In this picture, see the color sense of the bowel. This is the picture from 2014. I found it in my Google Photos during my PG life. And we have to resect approximately more than 2 meters of bowel in this case, and patient later developed short bowel syndrome. That means he had problems with digestion. Abdominal trauma, it can be blunt trauma or penetrating trauma. Blunt trauma is very difficult to assess whether patient is having bowel injury or not. If patient is having solid organ injury, liver injury, or splenic injury, patient will have hemorrhage, we can check it with ultrasound. Suppose blunt trauma causing bowel injury, it is very difficult. That's why high level of suspicion is needed. And in case of infection, suppose gastric ulcer perforation, it gives us time. Immediately patient has antecedent pain, now aggravating pain, then we can assess that patient is having this kind of gastritis, may have perforation. But trauma is there, only bruise outside of the abdomen, but no clinical finding. It is very difficult to rule out perforation in case of trauma. That is why in case of trauma, patient always suspect of internal, visceral or bowel injury. In penetrating trauma, obviously, suppose there is a step injury on the abdomen, and there is coming out of some like omentum or bowel, then it indicates bowel injury. So what assessment you will do? First, focused assessment for sonography. First, focused assessment by sonography for trauma.
EFOX is also there.
Yeah. Then a CT scan, and management is like if patient is stable, in stable condition, go conservative management, advice for investigation, do ultrasonography, CT scan, whatever is needed. There is it says that there is no visceral injury, we can go with expected management. Suppose there is rupture of the spleen or even laceration of the liver, but patient is hemodynamically stable, we advise for strict bed rest and we can manage conservatively. But if patient is hemodynamically not unstable, no need to wait for investigation. Hemodynamically unstable, our dictum in GMC was you have to take the patient to the OT within 10 minutes. 10 minutes. So that much important, because if he is hemodynamically unstable, then he is obviously having some kind of injury and no need to waste time. Give requisition for 3 to 4 blood and take the patient to the OT accordingly. Now there are some gynecological processes which also come with acute abdomen. These are like ectopic pregnancy. In case of fertile women, whenever you see patients with pain, whether it is right upper abdomen or lower abdomen, always suspect of ectopic pregnancy or keep ectopic pregnancy in your differential diagnosis. Then ovarian torsion, PID, that is written, always rule out pregnancy in women of reproductive age. Now, acute abdomen we have discussed a lot. What is the difference between medical or surgical? Whenever you have to give call to the medicine doctor or surgical doctor. Pain. In the first line indicates the surgical process. It is surgical and this one is medical. So, in case of surgical it is severely localized, and in case of medicine it is diffuse or variable. Guarding. In surgical cases generally guarding is present. In medical cases generally guarding is generally absent. Rigidity is common in surgical cases, medical cases rigidity is rare. Shock common in the late stage, but it is variable in medical cases. Bowel sounds generally altered or absent, and in medical cases usually present. And surgery, in surgical cases obviously surgery may be needed, but sometimes we can manage also in expected management, but in medical cases rarely surgery is needed. So because most important point is guarding and rigidity, it is generally present. If guarding and rigidity is present, this is generally a surgical case, not medical case. Why acute abdomen should have prompt management? Because if we delay the management, the patient may have different complications like septic shock, multi-organ failure, bowel gangrene, just explained, peritonitis, abscess formation, and death. If patient develops peritonitis with rigidity, mortality is very high. Sometimes it reaches approximately 50%. So the key message is delay in diagnosis is one of the major causes of mortality. So how should we approach? It is a teamwork. You are doing duty in the casualty, you cannot manage everything, so you will need yourself as assisting a nurse, 1 or 2, ward boy, then someone to run from here to there, like casualty medical officer, surgeon, anesthetist, nurses. Anesthetist is sometimes needed in the emergency itself because patient is having compromised airway and he may be needed to intubate immediately. That's why anesthesia is also important. Radiologist, because it is generally, casualty is generally situated close to the radiology department, ICU team and laboratory staff. The golden rule is early communication improves outcome. So this is the presentation. I am going to discuss a few cases, whatever we have studied now. So first case is, this is interaction. Everyone can answer. No need to worry. We have already learned this. A 24-year-old male. Yeah. That's right. It is for them also. For them only. So a 24-year-old male presents to the emergency department with 14-hour history of abdominal pain. The pain initially started as a dull ache around the umbilicus, but now shifted to the right side of the abdomen and becomes sharp. He reports a loss of appetite and 2 episodes of vomiting. On examination, temperature is elevated and there is localized tenderness and burning in the right lower quadrant. So what is the probable diagnosis? So it is possibly acute appendicitis. So how will you manage? Similarly, everything. Check for pulse BP, give IV cannula, antibiotic, analgesic. Then what investigation you will advise? Ultrasonography, abdomen. Okay, good. Next case. A 52-year-old female with history of chronic osteoarthritis treated with high-dose ibuprofen presents with sudden onset excruciating diffuse abdominal pain that began 2 hours ago. She described the pain as worst pain of her life. On examination, she is having tachycardia and hypotension. Her abdomen is completely rigid, board-like, and exquisitely tender to like palpation across all quadrants. So this is the X-ray that of the chest X-ray with including diaphragm. So what is your likely diagnosis? So hollow viscous perforation. So this is the X-ray I was telling. It includes chest and upper part of the diaphragm. This is the upper border of the right lobe of the liver, and this is the gas just above just below the diaphragm. And similarly also left side also, this is the gas under diaphragm. Sometimes fundal shadow comes here, then you see double shadow. So this is a case of, and sometimes seeing the amount of the air inside the abdomen, you can guess what perforation it is. The more proximal the perforation to the mouth, the more air goes out of the bowel. So it is probably duodenal or gastric perforation. So how you manage? Like everything ABCD, this perforation patient, in this patient, she is in shock. So we have to insert a white bore cannula. If needed to send routine investigation, check for hemoglobin status. If needed, requisition for blood, then X-ray, routine period investigation, and immediately shift the patient to OT after consulting with the attendants. A 45-year-old overweight female presents with severe cramping right upper quadrant pain that radiates to her right shoulder blade. The pain started roughly an hour after eating a fast food meal. She reports severe nausea and has vomited twice. On examination, she winces and abruptly stops breathing in when you deeply palpate in right upper quadrant. So what is the likely diagnosis? So it is acute cholecystitis. What investigations you will advise? So investigation choice is always ultrasonography whole abdomen. Okay, the management is similar. A 73-year-old male with history of atrial fibrillation, non-compliant with blood thinner and peripheral vascular disease, presents with sudden, agonizing, generalized abdominal pain. He described it as the worst pain of his life. On examination, the patient is in severe distress and sweating profusely. However, when you palpate the abdomen, it is soft, non-distended, and there are no signs of rigidity or rebound tenderness. The emergency physician notes that the patient's objective physical findings don't seem to match the sheer severity of his subjective pain. So, what do you think? Mesenteric ischemia. So there are some hint in history of atrial fibrillation. Old aged patient, and symptom is out of sign. That's why it is mesenteric ischemia. What is the investigation of choice for mesenteric ischemia? CT angiography. Ultrasonography cannot detect. X-ray cannot detect. Always go for CT angiography. If you suspect this, go for CT angiography, and we may need to take the patient within 5 to 6 hours in the OT. An 81-year-old female from a nursing home is brought to the emergency department with progressive abdominal distension, obstipation, and intermittent lower abdominal cramping over the past 3 days. She has a history of chronic constipation and dementia. On physical examination, her abdomen is massively distended, tympanic to percussion, and mildly tender throughout without peritoneal signs. And this is the X-ray, typical X-ray. So what is the diagnosis? Sigmoid volvulus. It is omega sign. So sigmoid volvulus is generally seen in chronically. I'll answer here. It is chronically generally seen in chronically constipated patients. Those we have Alzheimer or Parkinson's disease, because the loaded colon rotates, sigmoid colon rotates on itself. It is an emergency condition. We have to, in old patients, sometimes we can try hydrotherapy. That means injecting fluid through the rectum at high pressure, but it is not nowadays advised. We have to explore, re-rotate, and fix the cecum to the parietal abdominal wall so that it does not rotate again. Good. A 34-year-old man presents to the emergency department in extreme distress. He describes a sudden onset excruciating sharp pain that starts in his left flank and now radiates down in his left groin and scrotum. He also reports episode of nausea and a strong frequent urge to urinate, though very little comes out. On examination, there is tenderness in the right renal angle. So what is the clinical diagnosis? So it is obviously renal stone. So suppose this X-ray is not available from this history, what investigation you will advise? I have shown you the X-ray patient. you suspect renal colic, what initial investigation you will advise? So first investigation is always USG abdomen, because patient may have other problem also. It may mimic renal colic. So always advise USG whole abdomen. Simultaneously, you can advise for PP abdomen. So what analgesia you will prefer? Patient is tossing in the bed in pain. How will you manage? Just 3 injections. What do you use in the casualty? What injection is given? No, diclofenac, single shot diclofenac, then PPI and injection hyoscinics. Within half an hour, patient will go. 26-year-old woman is brought to the emergency department due to sudden severe sharp pain in the right lower abdomen that began towards the door. The pain radiates to her right shoulder. On physical examination, she appears pale, diaphoretic. Her vitals are like low BP, heart rate increased, temperature increased, respiratory rate is increased. On abdominal exam, there is severe tenderness in the right lower quadrant with marked guarding and rebound tenderness. So, what are the differential diagnosis here? Patient, young, fertile patient. So, always suspect of ectopic. She is having bleeding inside. So that is why you should never miss that suspicion of ectopic pregnancy in young, fertile lady. Always advise even pediatric. Patient will say that this month I had menstrual bleeding. These are not menstrual bleeding. These are spotting. That's why advise even for pediatric. This is the last question. A 24-year patient suffered a road traffic accident and brought to casualty. History of orchard sensorium and vomiting present. GCS is about 15/15. On examination, there is bruise on forehead and left lower rib case. Lip movements are normal. On examination, pulse is 116 and BP is 80/60 mmHg. What is your suspicion in this case? No. Tenderness, bruise on the left lower rib. Yes. So, one important point, and I have mentioned is limb movements are normal. So, always remember one thing, because you all are doing casualty duties. You all are doing casualty duties. You see patient comes with altered sensorium. We always pay attention to the head. Patient has vomiting, patient has altered sensorium, GCS, but we generally avoid the abdomen. And in case of blunt trauma, the abdominal, if it does not involve the liver or spleen or solid organ, generally the features are very inconspicuous. So, a patient with head injury can never go into shock. For shock to develop, the patient must have either abdominal injury or major bone fracture. In this case, limb movements are normal. That means patient may have some intra-abdominal pathology, and patient is having bruise on the left rib case. That means it is having injury. Most possibly, it is splenic injury. So, how will you manage it? Now first check whether the patient is in stable condition or unstable condition hemodynamically. If patient is hemodynamically in stable condition, give fluid and send the patient for ultrasonography. If patient is in unstable condition, suppose you have given 2 IV fluid bolus, but even patient condition is deteriorating, then shift the patient to the OT, simultaneously inform the relative and call the surgeon. If patient is having penetrating injury, just one point, blunt trauma abdomen, hemodynamically stable, you can wait to investigate properly, then patient may need surgery or not. If patient is hemodynamically unstable, then patient will need surgery immediately. In case of penetrating trauma, penetrating small knife, it is inserting in the abdomen, very small knife. Whether it is injuring the bowel or not, you don't know. So one thing is always insert the little finger into the wound. If there is peritoneal breach, then take the patient to the surgery immediately. If there is peritoneal breach. If there is no peritoneal breach, it cannot enter into the abdomen. That means the wound is out. The injury is up to the outside of the peritoneum. That means there is no internal injury. Okay. So with this, I conclude my presentation today. I don't know how much time is it taken. Hope it has benefited you. It took me approximately 1 week to prepare the presentation. If you get, even if you learn one word from this presentation, I think I have done a good job. Thank you very much for your kind listening.
Thank you, Dr. Sarfaraz Ahmed, Oncosurgeon, NAMC Hospital. You have presented well audio-visual presentation on acute abdomen. I hope our medical officers and also our senior officers also enjoyed the session very nicely. I was seeing that our HOD sir, Vipuleka sir, was trying every question like exam. So everyone is enjoying the question paper, the question answer schedule also. So I really thank Dr. Sarfaraz Ahmed for such a beautiful presentation. To prepare any presentation, you know, it's become very painful because you have to collect all the data, and he has shown us the audio visual presentation of his own cases, what he has done in his last post-graduation and super specialty training. So now I would like to welcome our few senior teachers like Dr. Vipuleka sir, Dr. Kullan Sharma, Associate Professor, Nagaon Medical College, Dr. Robertson Timon, and NAMC Hospital Director and Medicine Specialist, Dr. Sundaram Sharma, Dr. Monalika Koti, Dr. Liza Nazia Hussain, Dr. Inamul Haq, and our Dr. Manjul Islam from Rahat Hospital. I really thankful to you for your gracious presence here, and I would like to thank Dr. Jahangir Alam sir for your gracious presence. I can see our different medical officers from different super specialty and specialty hospital of Nagaon and Morigaon district, and all medical officers, those who have come, and your presence really make us happy and the seminar become fruitful. I hope you have learned something today, and we need such interaction in all specialty. Today is World Global Surgical Day. That means it is related to every specialty which is related to surgery. Not only general surgery, it is also for gynecological surgery, it is also for ENT surgery, it is also for orthopedic surgery, and basically anesthesiologists. They are always 24/7 with surgeons. So I really congratulate also them for today's World Global Surgical Day. And I would like to invite our special guest to say something on this special day. So Dr. Vipuleka sir, Dr. Jahangir, Dr. Kullan Sharma, sir, on this special day.